All right, so we're going to start with a couple slides to sort of frame sort of the current sort of state of the art or art of the state, and then kind of really sort of talk about some of the issues that sort of what are the hot topics as far as issues, and then sort of what's the action plan, what are the things that we as a community should really be doing moving forward. And so just as a reminder, so the ACTA trial, this was sort of alluded to, it was published earlier this year in the New England Journal by Tom Harrison's group. So basically showed that 1 week versus 2 weeks of AMFA was similar. And so I'm a little bit different than John, I guess, in that 2 weeks is ideal. You know, if you make it 12 days, that's not the end of the world. And so so somewhere in that sort of 1 to 2 week range is great. But certainly in resource-limited areas with deoxycholate, there's toxicity and things that pop up that negate that versus in high-income settings, that's less of an issue. Clearly, flucytosine is better than fluconazole as the second agent. Unfortunately, you know, flucytosine in the U.S. up until this year was $2,000 a day for treatment, so quite expensive. Fortunately, there have been 3 new FDA-approved generics in the last year, and so the price has come down by, I think, 60% over the last sort of 3 or 4 months as new agents come onto the market. Still in Africa, where the burden of disease is, you can't get 5-FC, and so we have these great guidelines of AMPHO, and 5-FC is the gold standard for therapy, but no one can actually get either amphotericin or 5-FC in most places, and in middle-income countries can at least get amphotericin. So lastly, the issue of flucytosine and fluconazole was a pretty good oral agent, and so an all-oral regimen in the ACTA trial, the bottom line had the best survival overall. It's not statistically different from the other arms, but that's actually a viable regimen. And then one of the things that we've focused a lot on induction therapy, but consolidation therapy really does have some tweaks that could be made. Historically, if you were non-sterile on your 2-week LP in the Vanderhorst trial, that portended increased mortality at 10 weeks. So we kind of know that, but among the people in Uganda anyway, 40% of them will still be culture positive at 2 weeks, and so you know that, and when you look at the patient, they look very similarly if they're culture positive versus culture negative, and so knowing that, we basically use higher dose fluconazole until basically they start HIV therapy, and we know that their 2-week CSF is sterile, and so generally we run that for 4 to 6 weeks, and then we drop down to the 400 milligram dose, and so at least in our cohorts, basically, if you're sterile or not sterile at 2 weeks, that doesn't really relate to increased mortality longer term. But the point, though, when you look at this, you still have a 20% mortality rate among the people who survive 2 weeks, and so can we optimize that therapy? I think is something that hasn't really been a focus, but moving forward, especially with some of the newer agents, may be an issue. And then lastly, just the point that the people who are picked up that have asymptomatic cryptococcal antigenemia, if you can treat that with fluconazole, they are going to have much better therapy, much better outcomes than those with symptomatic cryptococcal meningitis, even though they have the same CD4s, the same viral loads, the same sort of a degree of AIDS, that they just do better. And importantly, this is sort of the 5-year outcome data that we previously published in Uganda. If you can get people to survive 6 months, they're going to survive 5 years. And even these patients are still in care. They don't want to have cryptococcal meningitis again, and so they're pretty adherent to their therapy, actually. And then lastly, sort of the current WHO recommendations, which were sort of formed in 2010, 2011, based on expert opinion, and basically the 800 milligrams for 2 weeks. At the time, that was sort of chosen because nevirapine was still being used, and so fluconazole has a nevirapine interaction, and so starting ART at 2 weeks, we didn't want to cause harm to people, and so no one's using nevirapine anymore, and so that's not really an issue, and so that was sort of why the 2-week sort of higher dose was used, and then dropped down to 400 milligrams through 10 weeks, and then the 200 milligrams through 26 weeks. So the question of do you need secondary prophylaxis or not in this group, I think, is an open question. So if you see the dashed line is the 10-week 10-week point, and so most of these cohorts didn't use secondary prophylaxis, and so in the absence of secondary prophylaxis, there's not a lot of mortality that's occurring between 10 weeks and 26 weeks. And so improving sort of the induction therapy beforehand, certainly there may be a role to play. Importantly, these people don't die very quickly, and so even if you look at the high titer group, that mortality is occurring over 2 months, and so you certainly have time to intervene with better antifungal therapy and can potentially improve outcomes. And so sort of to frame, so that's sort of from the clinical perspective, some of sort of what I guess the state of the art is, and from recent publications. And so I think what we want to try to do, we'll see how successful we are, is to talk about sort of what are some of the issues and sort of what are the actions. And so I think from issues, we can start at the patient and sort of work backwards, so the microbiologic and immunologic things, clinical management. So I think there's sort of different frameworks that we can do. So, John, do you want to start the first question to their panelists?
Yeah. First thing I want to do. This is an interactive type situation, yeah. So I think we went through some excellent talks and discussions on the organism, treatment, the host. What questions do you have for cryptococcal disease today? Get up and ask us or ask this panel. Now, again, I never trust that anybody's actually going to get up and do this thing, but I'm hoping you do, and I'm giving you some time to do. But if you don't, I got my yellow pages out here, and I got a bunch of questions that I can ask these people up here if I have to.
John in the back over here. Hey, so, I think, amphotericin, flucytosine resource, available in countries like the U.S., it's very effective. It works. We can take care of people, but they're still incredibly toxic. They have a lot of dose-limiting things. So we've talked about a couple of compounds that are possibles. When might we see some discussion about, are these going to be trials that could happen in the future? Is that in the next 1 or 2 years? Is that 3, 4, 5 years down the road? What does the future hold? I hope not in 5, 10 years we're still using amphotericin and flucytosine. I think it'd be nice to have something equally efficacious, maybe better, but a whole lot better tolerated.
So what do you use? Do you use amphotericin B and flucytosine?
Yeah, we do.
Amphotericin B and
UAB with, Abelset, I guess would be the
I made that for a statement because there's really no good data that I'm aware of on the lipid products and flucytosine together. It's evolved over time, and it's very, very hard for us in guidelines to describe, to take away amphotericin B completely. But the point is, I think in our experience, the worst thing you can do is disrupt those first 2 weeks of therapy by having toxicity issues and not getting your flucytosine in and various things. And so we've abdicated, and that, including up to date, as I saw up there on that thing, I wrote that I think that Ambisone, which has a little more experience than ABLC, but I think ABLC would probably be okay, is a drug's of choice for your issue around toxicity, which you just can't have or don't need in that induction therapy time. Now, specifically to you with these new drugs, I think it's extraordinarily exciting that there are multiple drugs that have very potent activity against Cryptococcus. Shockingly, that you can set, as William went through that type of thing, and the possibility exists there. And I know, some of the times the hardest thing is not the target, not even the identification of the compound, but it's doing the clinical trials to get licensing. Yeah. And that's where we're at this stage. There's some compounds out there, and now with the priority review, those things can have some things around it, some legs around it. But remember, as was talked about, crypto never gets quite elevated to the level that it's one that everybody wants to use because they're going to make a bundle of money and stuff like that. They focus back on Aspergillus in Canada. I'm sorry, for us, even in the United States, or at least in our place, cryptococcal meningitis went down a little bit with HIV, some. It's picked back up with some of these fancy drugs that you talked about today and stuff like that, some of these checkpoint inhibitors and various things. It doesn't go away. There's still a significant amount of patients that we see here. But it's trying to get that study clinically done. Yeah.
So what's this? I think your question is, what's the status of the trial? So basically, there's sort of 4 things I think that are in the works, and so probably the furthest along is the oral amphotericin product, and so that we're hopeful to do a phase 2 trial maybe next year. for that. The Amplex compound has gone through a phase 1 safety study, so that looks very good from a toxicity and safety perspective. And so we're starting discussions and looking for funding for a phase 2 study for that. The Viamet, they're hopeful to start a phase 1 safety toxicity study with NIH this fall or sometime in the coming 6 months, and then that'll be a year or two, and then looking at phase 2 studies for that. And then lastly is the neurophoresis, which is basically looking for sort of a phase 2 study concept for that and funding for that.
And as Peter said, the Tokiyama drug might be back on the arena. It has quite a bit of baseline data. Peter?
Yeah, I was part of the discussion group with the original or the first Viamet compound, I think 1129. And despite what the animal models had shown, showing pretty design, we really got muddied, or just really slowed down over the need to have everybody on amphotericin plus the new compound. There was a real reticence to put a person on this new compound alone, despite the fact that you had abundant animal data suggesting that this was as good as anything you had. And, if you take William's comments to heart and what I've heard, you talk about before regarding animal models and how they can be extrapolated to humans. Of course, I'm going to be in these discussions, but I want us to be bold and about saying, yes, we can try monotherapy with Agent X, whatever it happens to be, if it has shown, in animal models, really robust activity. Because barring that, we're going to get really bogged down with these clinical trials and having 4 and 5 different arms, and then gradually dropping the amphotericin or so, and then moving them over to a single arm. I just think we need to be bold, within limits, and also creative. Not saying screw the FDA or any of that kind of stuff, but just I think we need to be aggressive about how we do this. So, just a comment.
Josh, do you want to talk about the ethics of?
Well, yeah, I mean, it can be challenging, the ethical part. I mean, obviously, in terms of, getting ethical approval, standing in front of sick patients, also, it always feels better to have that amphotericin as part of your therapy, and I think we really haven't pushed them though either, in some ways. So I'm not really sure how like in Uganda, for instance, they would take a new compound. I think if we had some data, especially if we had a little data in the U.S. as well from humans, it may make it a little bit easier to get some of the big trials off the ground.
Yeah.
But you're willing to give, we are willing to give patients monotherapy with fluconazole at a higher dose, and that's okay.
Well, I wouldn't have done that study.
Well, and yeah, I guess it depends on the site. Yeah.
It's illogical. We say it's okay to give fluconazole, a drug that we know doesn't work as well as amphotericin. We're just going to augment the dose. We have a compound here, or 2 or 3 compounds here, that actually kill the germ.
Yeah.
It just seems illogical.
It's just it's a pretty touchy subject. Just, last year, when at CROI, when we presented the sertraline data, there's 2 of us talking about crypto in this session. I don't know if others were at this session. And so I went second. Before me, they were presenting the fluconazole monotherapy data, and really, got attacked pretty hard from the audience about that study in general. And that was done in Kenya, in a site where quite
In
likely
South
they
Africa.
didn't have access, may or may not have had access, at least at the beginning, they didn't have access to amphotericin. And yeah, it's just, it can be touchy. So, you know, when, at least at our site, we feel like we're able to provide standard of care therapy. And at sites where we haven't been able to provide standard of care therapy, like in Ethiopia, we've run into problems with our own IRB at Minnesota. And so it can be a challenge.
Yeah.
But I totally see where we're going with the comparisons in combination drugs. I mean, I just had this discussion with Damian Christen from Iowa as well,
Yeah.
who did the tamoxifen study. And I mean, it's really difficult to show any sort of superiority when you have 3 drugs on board. How are you going to show, you know, especially when one of the drugs is amphotericin? I mean, it's a real challenge.
Well, just to keep the analogy, Pete, in invasive aspergillosis, we're prepared. That's you know, the mortality is 20%, and we're prepared to use monotherapy in phase 2 and 3. We don't have any problems with that. And then just something maybe I didn't bring out as well as I should have in my talk, but just to speak again to, this is such a disease that lends itself so nicely to this problem, because there's the murine model, but there's also a rabbit model, and you can get sort of 2 reads on the problem. The mouse tells you a lot about the brain, and the rabbit tells you a lot about the CSF, and they're probably 2 pharmacologically completely distinct compartments, but they're complementary models. They're very powerful models, and they talk to one another. So if you can't do it for this, you probably can't do it for anything. So I just think that we're putting blinkers on ourselves, that we're locked down in a paradigm that is of our own making. That's my...
And of course, the other question that is going to be really touchy when doing clinical trials in Africa is this something that, if it works, is it going to be available to us? And so that's, I think, a huge question. And so when we're doing something, you know, like sertraline, or, I mean, we're running into this problem right now with flucytosine. So,
But that's also an advocacy problem.
Yeah.
And it's also not only in this space, it's in the antibacterial space, because where do you think you're going to study the new metallo-beta-lactamase inhibitors? You're not studying them in the United States, you're studying them in these sorts of countries, and we just have to fix these problems about parity and access.
yeah, and I think, like with Biomed at least, I mean, they understand the situation as well, and they understand that there may be a market for it, but the market is not going to be in Africa, where most of the cases are, and I think that they recognize that they would find a way to make it available in that case. And so, but that's important to sort of think through before, I think, starting any clinical trial.
If I may, I'd just like to address the question that Peter brought up about the laboratory animal data. We obviously have gone into, collectively as a community, into, as William had alluded, to life-threatening invasive aspergillosis, candidemia, invasive candidiasis as well, predicated upon very powerful predictive laboratory animal model systems. Our own system, 11 different compounds, highly predictive right down to the microgram per ml. The crypto data in John's hands in the crypto animal model has been highly predictive. William has worked with the system. Is it then more of a question of education? In other words, compiling the predictability and demonstrating that, yes, indeed, one can predict from bench to bedside outcome and not necessarily rely solely on the emotional content of saying, well, I feel good that I'm giving amphotericin B. When we've approached our patients with other diseases other than Cryptococcus, life-threatening diseases from mucormycosis down to aspergillosis, literally A to Z, we've actually presented some in a manner that patients can understand, in a manner that our residents and fellows and attendings can understand. We're offering something better by way of efficacy, safety, tolerability, and patients and families and attendings and resident and fellow staff understand it. And the animal model data are an important part of that conversation and awareness. I think there needs to be more of an educational awareness in our sense of advocacy of bringing from bench to bedside the laboratory animal data from predictive models.
And I think that's one, I mean, that's one of the problems with Cryptococcus, where the therapy hasn't changed in 20 years, really. I mean, since the Vanderhorst trial, we're still at the Vanderhorst trial, basically.
Yeah, I think I think it's important that people brought this thing up, because I think that in the development of these drugs, if there's 2 or 3 or 4 of these things coming down the like, I think it's very important to figure out exactly what's the best way to develop them. And like William said, I am much more for monotherapy on these things. If they pass the test, Pete said, well, you know, we've already known with some of these drugs. Some of these drugs, they work very well. They work very well in screening with the mice. My experience has been, I would personally put it in the rabbit too, because as you talked about, there's different stresses on those things. And the truth of the matter is what these guys are going to do when they put it in the humans, they're going to look and see how fast they can kill in the CSF. And that mouse may not be as predictive as the rabbit, at least in my experience. So I think they have to be, and it's not just I'm not sure it's all just the patients and the countries and stuff like that. I think a lot of it is us. I think a lot of it is the development, the companies that are afraid, and I think even some of the experts are afraid to do these type of things. And yet, it doesn't make a lot of logic if you think about aspergillus and various other things that you couldn't use monotherapy in these things. Plus, with crypto, it's not something that you can't watch pretty closely. I mean, one of the great things of cryptococcal disease is to study it, actually, because you can study it at the site of infection sequentially, dynamically, over time.
Yeah.
In Canada, you could do a little bit with blood culture. Aspergillus, the galactomannan, if anybody wants to use that. This is just such a nice, around-the-box type situation, and it's been validated. The EFAs have been validated for outcome later on.
Although EFA it's a surrogate measure, it's not a perfect surrogate measure, though.
It's not, but it's a one that can get you by that first
It's the first
stage.
hurdle. Correct.
That first stage in humans.
Yeah.
And
So what are some challenging patient populations? So I'll ask Josh again, because I know what you're going to, I hope I know what you're going to answer. So obviously, so I think it was alluded to in some of the talks, the transplant population we don't know a whole lot about, really optimal therapy. The non-HIV, non-transplant population we know even less about. Within the HIV population, there's certainly some subgroups that have higher mortality still, and so I don't know if you want to mention some of your observations with antiretroviral therapy to prompt you.
Well, yeah, so I mean, so right now, our observations in being in Kampala over the last 10 years or so is that I think in general, taking care of cryptococcal meningitis patients has become more complicated with better availability to antiretrovirals. And so we sort of did cope first, and I think that's recognized that that we should be focusing on clearing meningitis from the patient before we start antiretrovirals. But we're seeing more and more cases of patients not getting screened with a cryptococcal antigen test and presenting to us with cryptococcal meningitis after already starting antiretrovirals. And we feel that these patients are at high risk for mortality. And then, so there's that patient population. And then there's those that have been on antiretrovirals for years and are coming to us. They seem to do okay from a crypto standpoint, at least in the short term. But these are the more complicated, potentially non-adherent patients, and trying to understand, if they're failing their antiretrovirals or just non-adherent patients can be a challenge. Other challenging patient populations, we actually are seeing more than you'd think. We see quite a bit of crypto-related disease in pregnancy, and we're not quite sure how to approach those patients, especially when it's asymptomatic antigenemia. If we should be putting them on high doses of fluconazole or not. Just a few of my thoughts. And relapse patients as well. we're seeing more and more relapse patients, and not sure if we should be treating them any differently or if we should be more aggressive. Kind of just take all of these on a case-by-case basis, really, without any sort of guidelines to direct us.
So the first point that Josh had brought up about the patients showing up on antiretroviral therapy, so there's a big push by PEPFAR and others to really sort of the test and start, so where you're HIV positive and you then immediately start your HIV therapy the same day. And so people are coming in unmasking their cryptococcal disease shortly thereafter. And so what Josh has published is basically that group that have recently started within the last 2 weeks have basically a twofold higher mortality rate. And so instead of a 35% mortality rate, their mortality rate is 70% with amphotericin and fluconazole therapy. And so that's a problem. And so do you stop ARVs? Do you give steroids? You know, other immunomodulatory things, because it seems to be a little bit more problematic.
Right, and I think what we were talking about earlier too is there's been a lot of focus here about new antifungals or different regimens to play around with, but I think we still are neglecting the immune response in the whole process. And I think even if we had the perfect antifungal against Cryptococcus, there's still going to be some mortality just attributed to the host immune response. And I think that's what's made the antiretrovirals a complicating factor in our patients, and why I think the non-HIV population is so difficult to take care of.
Since we're talking about patient populations and stuff like that,
Yeah.
we focused on the resource-limited world and the experience and the massive experience you have. As I think about it, and occasionally at night when I'm typing up my clinic notes and stuff like that, I keep thinking that all this data is going someplace. In the United States, everybody is hooked up to everything. So I want to ask Lisa Ann a question, which she actually partially brought up, and so I'm going to give her a chance to talk about it, is should we be in the arena of finding out what's really happening with patients like in the United States, where everything is hooked up, all the data, and people spend money on all these proven databases and various things. Should we as an MSG place start to think about the idea of being invested in that, spending money on that, getting that, and then having the young people in the audience and stuff like that interrogate these big data sets? Because as I look at this thing, we've got to think differently a little bit, and I think if you get these massive numbers of patients that are sitting out there, and there's quite a bit of data on them, and we could do it a different way. And so she's thought about this, and so I'm going to give her a chance to talk about it.
Yeah, well, thank you. You know, I think that we have the opportunity to harness the EMR. Most places have Epic now. It's still a billing tool in my place. I mean, you have to go to Wisconsin and learn Clarity and do all this stuff to get data out of it. But I think there's been no advocacy from any, group that I know of at institutions to do this. And, we've taken care of a lot of patients in the U.S. over the last whatever period of time. And I think it would just be so useful to use a machine learning, artificial intelligence, whatever sort of approach to take everything that we know about the patients that we've taken care of. Did they have a cough? Did they have an abnormal x-ray? What are their platelets? Because it will help us, I think, generate some new hypotheses and think a little bit more outside the box about what may be going on with our patients. I will say that in the Bronx, I think the major crypto that we see right now is unmasking because of test and treat, because of opioids, because of non-compliance with medications. And, patients doing fairly well, being put on ARVs and coming in anywhere from 2 weeks to 6 weeks later with crypto. So I don't know how much enthusiasm there is for this. We do have someone at our place who's begun to use this approach to look at ventilator-associated pneumonia. It's been used recently at Stanford and stroke sort of analyses. And I think that our population is really, primed for this. And I don't know whether we have big data people associated with the MSG or whether you could recruit someone to help, but I think it would be so important.
Yeah, I mean, there certainly are big data at all of our universities. There's people doing big data stuff. I think part of it, though, is still it comes down to a retrospective chart review, and that you're going to have to someone's going to have to probably go through and code stuff and actually look, and because it's not like there's a tick box on do they have a cough.
Well, yes, although there are apparently more sophisticated ways of getting things out of EPIC, and phenotypes I think are really important. I mean, even Barry Kohler is like into phenotypes these days. And it just seems to me that I think you made the point really well. I mean, when I was an intern, in 1982, every crypto patient was basically the same. They had 2 CD4s. We gave them the amphotericin because it was considered, chemotherapy. And they all did miserably. And that was basically it. But now there's so much complexity and heterogeneity in our patients that I think it would help us to know. Tom?
I just wanted to address the pregnant females who are crypto antigen positive, otherwise asymptomatic. At least in terms, it certainly merits really a very targeted approach, because the cell-mediated immune impairment, of course, associated with pregnancy could accelerate their disease. But moreover, if you consider the role for fluconazole, the greatest concern, at least in this patient population, is the craniofacial dysostocia. But that's going to occur, the thinking is, and FDA guidance is, it's in the genetics would indicate that it's in the first trimester. So if you encounter second or third trimester, it would be quite reasonable then to intervene and potentially help that population.
Yeah, it's the first trimester, folks. And so we've sort of taken a very customized approach. And as with everything, they always get excluded from clinical trials. But we look at titers and look at progression over time. And so we've done weekly amphotericin infusions, various sort of things. And so at least to get them out of the first trimester before we would put them on fluconazole.
David, I was wondering if you could go back one slide to the sort of the stratified, asymptomatic cryptococcal anemia patients. I'm just wondering, with high crag titers, in your experience, what is the mortality due to cryptococcal disease versus other HIV-associated? Is this just a marker of immune dysfunction rather than
so that's a good question. So what do they die of? And so that's always, and even with the cryptomeningitis patients, what do they actually die of? Is kind of tough. And so we've done autopsies on these patients, and so they all have disseminated crypto everywhere, whether they die of a PE or whether they die of their crypto. And so the majority of these, it's sort of a mixed bag, but a lot of it's probably crypto related. So some of it's clearly CNS, and so you say, okay, that's crypto. Some of it's pneumonitis. You say, well, that's probably an immune reconstitution due to the pulmonary crypto. Some of it's just sepsis, so they just come in sort of septic and likely have sort of disseminated iris phenomenon. So it's a mixed bag. When we look for TB, we look for other things. We don't find it. So occasionally we'll find someone with TB among this cohort, but we're doing other diagnostics looking for other OIs. They're all on cotrimoxazole, so they're getting their Bactrim prophylaxis for toxo and pneumocystis. But a lot of it's a mixture of CNS, of sort of pneumonitis, pulmonary syndrome things, and sepsis is sort of particularly among this population.
I have another issue because I don't want Tom to fall asleep here. So,
I guess, and the other, sorry, David, or Andy, the other thing is, so Ray Wake in South Africa has also done autopsies in these populations, and basically the people who die have crypto in their brain as well. So even though they may be asymptomatic on autopsy, it's present.
So I have some issues, and two of them. This is for Tom and Andy. The organism. Do we need to push harder to identify what these organisms are? The taxonomy thing is, massively discussing, talking back and forth. One group in one thing, one group in the other. Physicians don't want to actually hear that. They have enough names. But honestly, for the CDC and for in general, is it coming to a time with all the genomes we sequenced, all the kind of understanding we have, is to get people together and come up with one nomenclature for Cryptococcus neoformans, or Cryptococcus gattii, or all the genotypes related to that. Surely editors are pulling their hair out now because everybody does their own thing and stuff like that. But I think even for the clinicians, we got to come to a point where we have some consensus. The second thing on that is something that we've talked about multiple times here, is repositories, strain repositories. And I think the CDC has suggested that there's the possibility that they could store those things and stuff like that. As Andy, you talked about, there's a very plastic genome and stuff in these type of patients. But on the other hand, if we just throw them into the box in the incinerator and stuff like that, we may lose the ability to find out the bad actors and the good actors and the various things. But we've got to have a repository or some place to put these things that all the investigators, the basic science investigators, can go and pull out their wild type strains. So my question is twofold. Number one, should we be pushing, MSG potentially be pushing, to try to bring together a group of taxonomists and stuff like that to actually come up with some type of formal structure that seems reasonable from both the phenotype and from the genotypes? And two is, should we continue to push to try to have biorepositories, particularly for strains? Of course, I'd like to have DNA and stuff like that too.
Well, those are two great questions, and I will put on my Tom Chiller hat a little bit, so I don't represent the CDC necessarily, because I have pretty strong opinions, as you know, about some of these topics, like William, and my thought on, I love taxonomists. I know John is in the room, so I don't want to say anything bad. I love taxonomists, and I love the fact that they do this amazing work. But with my clinical hat on, it drives me absolutely insane. And I think that we do need to, the clinical side of managing patients, which is what this group does, needs to, I think, come to grips with more of a realistic view on how we can explain these already complex organisms to our colleagues that are out there that aren't mycologists, that aren't even infectious disease doctors, perhaps, in a way that's simple, that's explainable, that yes, you're treating crypto, you're not treating Deuterogatrii, or you're not, so I think that whenever these new names come out and you go and you talk to clinicians or even healthcare providers, et cetera, it's challenging. It makes our job really challenging. So I do think MSG, and I suggested this at Isham, John, with Sibrin, because Sibrin is, again, another taxonomist, that there needs to be some, maybe there's the taxonomy and there's these wonderful genetic names and definitions, et cetera, but then there's these clinical, whatever, species complexes that have very similar treatment strategies that we can use to explain to the general clinical group about how to manage these diseases, et cetera. So I do believe that is a role for MSG, and because you guys are the clinicians, or we are the clinicians. And so yeah, I would advocate strongly for that. I do think, however, at CDC and maybe other organizations like us, that doing whole genome sequencing on Candida auris has been incredibly important for us to track this organism. And so I'm not saying that it doesn't have utility in public health or in understanding the emergence or the spread of organisms, but I think simply back to the patient, yes, it would be nice to have simpler definitions.
John, may I offer a comment as well on this? Sibrin and I were working together, as well as a number of other colleagues, on what was basically the Isham Nomenclature Committee. And we had two publications coming from that in which we asked for a certain level of threshold of validation. It was certainly the molecular taxonomy, the evolutionary biology needs to continue, but there has been enormous confusion with breakdown into multiple species. This is not just pertaining to Cryptococcus, enough that Sibrin convened a group of individuals to try to address this. It made some headway in terms of asking for some type of validation, but then the committee just somewhat lost steam in it. Where it came up again was in our 6th edition of medically important fungi. Many of you use it or have seen it. This is Devise Larone's book. She asked me and Randy Hayden, to spearhead that 6th revision. We went through every organism that's in that book in reviewing the taxonomy over 2 years' time. And there were some where if you trace back into Dr. de Hoog's original atlas, you'll see that the same laboratory changed the name over the course of several years, several times. And so we said there needs to be some, to use Sebrin's term, nomenclatural stability. So we put footnotes for pertaining to the organisms. Unless there was some clinical compelling correlation, we for example, in Candida rugosa, changed multiple times, multiple different species, not at all clear what it means, a footnote to say, these are some new species, this is still Candida rugosa. Bipolaris, we all know what bipolaris looks like. There was a comment that said, oh, it should be curvularia. Even Sebrin said, no, it should be back in bipolaris. So there needs to be, and maybe MSG can take up the torch that was somewhat dropped by Isham, or maybe we can reconvene it, for the spirit of nomenclature stability. Another analogy that was brought up was, in all of our laboratory work, we look for validation, for standardization and validation that comes into the laboratory. But if one laboratory happens to just identify an organism and tries to change Rhizopus oryzae to Rhizopus delamar for whatever reason, and then expects that that's going to be used, well, you can't expect without validation and clinical correlation that it will be used. So MSG has an opportunity, perhaps working with Isham, taking this kind of approach of putting some spirit of nomenclature stability before it just becomes a massive confusion.
Pete.
They keep mentioning the MSG, and I presume what you mean is you want an advocacy group that advocates for the clinicians to bring some common sense to this, and that is I think legitimate cause and something that could be done. It'd be simply a matter of pulling interested parties together. I do want to kind of bring up one thing that we've also been kind of circling around, but nobody's actually come out and said it, and that is, are we suggesting that we do another registry? I mean, it sounds as if we're suggesting that would be a useful thing to do, certainly in the U.S. Now, we're doing that in MSG 11 now, but we're limited in terms of our sites. Sharon is one of the participants. We have a site in Taiwan, et cetera, collecting samples that can be shipped or going to Tom, but it's on a much smaller scale. If you'll remember, Karen Marr's study, which ended now over a year, maybe 2 years ago, enrolled 150 non-HIV patients within a matter of about 18 months. Now, that was an NIH-funded study. It was technically an MSG study, never really was. And she did all the things that we might want to do. That is, followed them 2 years, got immunologic parameters, et cetera, et cetera. And sites got paid a little bit for it. But it seems to me that we could do a downsized version of that has a broader net. And I guess we would. I mean, there are questions that I would love to know from Tom. How dominant are these quasi-species and how important that is clinically. It'd be nice to have that information in hand. I don't think we're going to get that from Karen's study. It would be nice to know how people are currently treating them, et cetera, outcomes, et cetera. And somebody to really define that there are not 3 groups, but really 4 groups of these patients. They're HIV patients, they're transplant patients, they're the completely normal patients, and then there's that 4th group of non-HIV, non-transplant that are, renal failure, liver failure, et cetera. Those are the patients who do the worst. They do and nobody's really looking at those. So the question that the group has to ask is there value to doing that in a robust, prospective manner, recognizing that there's not going to be a clinical trial designed, towards that end. And if so, is it if it's important enough, can we generate enough enthusiasm from potential sponsors to fund that effort? Because you're talking about, 1,000 patients.
So just in general, I've always said, I've offered CDC as a place for, a repository, a biobank or whatever. I've offered that because we do have a very big management structure that's off-site and that you can access. I think we'd have, the devil's in the details of what that means for you all, because we couldn't have one of you asking us every day to pull this and pull, so we'd have to come up with some way to do that that isn't too onerous on us. And there's been an experiment recently, many of you I think have actually got strains this way, but the FDA and CDC joined together and formed this AR bank, and they put isolates now in this AR bank, and you can access them online, and they will ship them to you for free. So we had 10 Candida auris. We may have, Sean keeps putting more Candida out there into that AR bank so that you can just get them. And so that could be another way in which we could, you could have access to something by simply going online and ordering what you want. If you knew what was available, that experiment seems to have worked, and a lot of people have gotten Candida auris that way. And so we haven't had to go sub it and do that kind of stuff. But that facility is there, Casper, it's called, and I do think, like, I'm a little frustrated, for example, with the big. Tom Walsh mentioned this earlier, but NIH funded a big study with John Wingard, and they have all these samples, and then what NIH does once that funding's over is they say, okay, now it's on you to maintain that biobank. And so then they're trying to find money to keep the freezers going and all this stuff. That's one thing you wouldn't have to worry about with us. So I think that there's an advantage, and so we would keep the freezers running forever unless the government shut down or, for a long period of time. But basically those would keep going and you guys would have access. But I think we would have to set up the rules for how that works. But we're completely willing, blood, urine, isolates, bowels, whatever.
So Pete has reminded us that we should finish it on time at 6 p.m. Yeah. And so we got about another 15 minutes or so. And so maybe, I don't know, should we shift towards sort of action items or? But Sharon wants, after Sharon says something.
No, sorry. I was just going to make a comment on the biobank and on John's and Tom's and everybody else's comment about the isolate repository. It's so important, I think. And, if MSG can help, I think it would be a positive thing. So we have a repository in Australia as well. I know we're very much smaller, but ours is linked to CBRN's repository. So there's a central database. It talks to one another. It's common, share strains, type strains, non-type strains, mutants, whatever you like. So I think there are huge advantages in having a repository and sharing the data, the metadata.
I think the biorepository, I think, is most useful when it's linked back to the clinical data. So you know what happened to the patient, and you know the phenotype of the patient, because then you can sort of put everything together. Because if you just have the isolate alone, then that's just like stamp collecting, and you don't really, you can't really do much with it. Versus when you know the clinical outcome and the phenotype of the patient, which then gets back to collecting host issues of
it's
DNA
always
and
nice to have
RNA,
that, but actually in this day and age, you've got a lot of stuff. You've got the whole genome sequence, you know where every gene's at, what polymorphisms there are. Yeah. We need to think when we got these things to try to strategize, to put these things in arenas. Like your place, because one of the things that happens is all us as individual investigators, there's no money out there, the freezer's got to go by the wayside. And you don't want to lose the repository, the clinical information with those, the sequencing, the transcriptional profile, the proteomics and stuff like that. They're coming, and the mutant profiles. And we got to figure out a way to actually put them where they can stay and somebody can then access them.
Okay, so action items. So one action item is biorepositories. Okay. William, you're looking perplexed at me. Okay.
I have
other sort of action items. So
other action item that Pete wants and stuff like that. I think we need to talk how maybe MSG and ISHAM and the taxonomists can come together with some type of meeting to kind of talk about what Tom talked about, stability of the nomenclature. And it's not just crypto, it's just that we're talking about crypto, but in general, to kind of try to stabilize this in an arena now where we have quite a bit of genetic information. We have quite a few genomes and stuff like that being sequenced. So it's not naive when we come to talk.
One question that I have about repositories and the clinical stuff is, and we heard about the plasticity of crypto and how that's preserved in repositories. So I remember I got Tahana's strains when she initially reported fluconazole resistance all those years ago, and we redid the MICs and it all disappeared. So how do you do that?
I think it's an extraordinary issue. Andy brought up the plasticity issue, and I think it's very important in how we do those things and come up with standards to actually put those things into the repository, because you're right, it's a very plastic genome.
But I think the other thing too, I think one of the things that leads on is one of our great legacies is going to be the, with the damage response paradigm, the idea that every infection has to be considered, an interaction of the specific host and the specific microbe. And if you think about these biorepositories, this is a little bit challenging. Think of the host. Think of your patients. There's time is another dimension. It's not just it's not just their genome at one period of time. So what differentiates some of these patients from the ones who do well, who don't, is their ability to recover from infection, not just the intensity of their immune response. So it will be a transcriptional profiling with time. And so it adds challenges to the concept of the biorepository if you have serial samples. But I do think that is the real issue that we need to, because if we're going to get beyond steroids, if we're going to have actually specific, precise therapy for these patients, we're going to have to immunoprofile them and know what is the signature of a successful recovery from infection. What is the signature of someone who has asymptomatic CRAG positivity who goes on to infection, and how are they responding immunologically? Therefore, we can target that, because I think we're reaching an asymptote of outstanding antifungal therapy, and what we need to do is we need to actually now optimize the host.
I have a question for those of you who work in, why CRAG positivity is important because it's telling you there's crypto there. But this asymptomatic, it matters for the patient, they feel better. But how important is that really? Or is this telling you something about the fungal burden in that patient? Or you said that there were patients who were CRAG positive who at autopsy had stuff in their brain. So I'm wondering whether asymptomatic isn't a helpful term, and whether an action item might be to try and come up with other definitions that are quantitative, to go by titer. Because you're going to treat a patient with a very high cryptococcal antigen titer, and you said, I was happy to hear you say it because I do it too, when they have a really high titer, you put them on full-on treatment. So I'm just wondering how useful that asymptomatic concept is, and whether it may be holding us back from doing some of the things that Andy is saying, is really thinking about that host microbe interaction. Maybe the patient is different because the organism is different, or maybe the patient is different because they have IgM. I don't know.
Unresponsive.
Yeah. So,
let me just cage that.
okay.
Let me just cage that for a second with my public health hat on, and why we talked about asymptomatic. Because you can talk to the president of a country. You can talk to non-medical people, and you can say asymptomatic. No symptoms, we need to screen. So this was really about a strategy, I have to admit, by me a lot and by others, to get it into countries that needed it. And then I totally agree with you. With my clinician hat, we should be doing this by titer. I mean, we shouldn't be talking about asymptomatic, because it's a very subjective thing. Who doesn't have symptoms with a CD4 count of 4? For
they
the
have
most part?
symptoms of AIDS. They
But
have
that was
symptoms,
really,
but they don't have meningitis.
But I just want to say that's really why we pushed hard on that word, because it was understandable to the layperson and to the stakeholder and to the congressman and to the minister of, that we needed to advocate to.
Okay, we got 5 minutes. Pete wants us to do any more issues. You want another accident issue?
So registry, was that on, did that make the list there, Masa?
Yeah, yeah.
A registry. I think registries are, yeah, I mean, registries are particularly useful for rare events. So we don't need a registry for HIV positive crypto, but for pregnant crypto, like, ooh, that would be, yeah, non-HIV positive.
But I would
be
also
good.
say the biobank concept has really, as you guys are all saying, has matured. It's not just the isolate anymore. It's a blood sample. It's the patient's blood sample. It's history. And I do think that so we can almost, I mean, I would be the first guy as a data person to say registries are useless. I can't analyze them. We went through this with transit and then OTIP. But now I have come full circle on my thought process on that because of people like, Michaelis and these people that are doing these. And so now maybe a registry, it's a little different. It's a little deeper. It's thicker. It has multiple samples of that patient there, and it has a history. And we're looking at these immune issues and genetic issues of the patient. And I know John, when we were running the fungal meningitis stuff, John said, oh, you really, Tom, should collect blood on all these people because someday you're going to want to know their genetics and why they're getting fungal meningitis. Sure enough, we couldn't do that. We just couldn't get out there and consent them all. But we do have CSF on almost all of them, and we're giving a few of those to Michael to see if he can get some DNA out of the CSF. So thankfully we have the CSF. But yeah, so I think I'm not necessarily opposed to a registry if we think of it in different terms.
But you're right. It needs to be deeper, more robust than just patient had crypto, underlying disease, age, that kind of stuff. I agree. That's almost useless. We have enough retrospective data
Right.
to do that. I mean, you're talking about a robust. You're really talking about a robust registry, one that comes with all the bells and whistles, including, it has to have genetics. It has to have genetics, and it has to be paired with an isolate when that's available. I think that'd be extremely useful. Paying for it is going to be the issue. I think nobody would argue that that's an important issue. Paying for it or convincing somebody to pay for it is another thing altogether.
So, Pete, one of the things I think with your registry, we were talking about big data and stuff like that, was going past these registries, sucking all the data coming out of these patients throughout the country. That's something that has, bioinformatics people, us to try to figure out whether as clinicians we can help them on that. People are doing that thing today in a lot of different ways. Should we be interrogating that? Could we have monies to go out and get these databases?
Well, I mean, we've looked at a lot of different data sets, and the problem is how good are the data? If it's administrative data, there are coding issues. The definition of cryptococcosis is not always perfect. And you're left with missing variables, like a lot of times drug, how many days, duration of therapy, what dose. I think with the big groups like Vizient and everything, that data, you can get pretty good data, but it costs a lot of money. Hundreds of thousands of dollars sometimes to get the data sets. And then you have to get the statisticians and big data people to look at it, and it's pretty complicated. So, I mean, I think it's worthwhile. We used it for a Canada paper a couple years ago, and we've done some other things looking at epidemiology of endemic mycoses, but I think it's worthwhile, but it's a money issue.
Other action items that we can accomplish in the next 2 years, so when we come back here 2 years from now, we can have accomplished something.
Yeah, just one quick thing for Sharon here. Do you think at this stage we should be aggressive about identifying Cryptococcus neoformans versus Cryptococcus gattii? Is there a therapeutic or prognostic factor that we should be doing, just on the basis of, the Molotofs can do that stuff for you.
Well, I guess that relates to your question about the taxonomy as to how far you want to go. So with neoformans and with gattii, I think it is probably reasonable to differentiate them, and to this end, I'm on the side of the taxonomists where they want to separate neoformans for gattii. Within neoformans and gattii, that's more debatable. in answer to your question, John, I think there is a difference in the clinical presentation, and John Badley would know very well the data from MSGERC, and just our experience and the experience of yourself and the Canadians. The treatments are different in terms of the length of induction therapy, the total duration of therapy, and the kind of monitoring responses. So yes, I do think they are different diseases. Does that help?
Yeah, I think it helps. And so John's back there. They've got a bunch of data from MSG to kind of look through that type of thing to allow us to say, yeah, we need to do that, or no, we don't need to do that, or we need to break them up a lot more than just Gaddii and neoformans.
250 Gaddii and 450, 550 neoformans. And so, interestingly, there are quite a few differences in the two groups. Actually, I have the preliminary paper to give to you tonight, John, by the way.
I knew we'd get around to that.
And Sharon and Pete have seen it. But anyway, it's got some work to go. But interestingly, I think a lot of the differences are probably going to be explained by a host and really immunosuppression. And I think a lot of the glamour will be less glamorous. And there's a separate group just looking at Gaddii, looking at the different strains, Australia versus Washington and Canada. So I think we'll find some interesting data looking at genotypes as well.
Yeah, and that's what I was going to say. I don't think you need to differentiate Gaddii and neoformans. I think you need to understand the host. But John's got the data, so let's see. But I think you can just say crypto. But it depends on the host. What kind of host are you treating? An HIV patient in Africa, or are you treating a transplant patient at Duke? I think that's the difference.
In 2 years, we'll come back and let's remember that.
All right, so it's 6 p.m., 6:01 p.m. So,
Yeah. So I'm not trying to be a jerk about this, but the fellows have only this hour from 6 to 7 to stand by their posters, and it's an hour for those who aren't interested. It's an hour to rest before we go to dinner at 7. So, great session, great talks, all of you. That was terrific, and nice discussion as well.